Today we are going to discuss some of the measures we put in place as KNH, an institution. And as all of us know, it's about 5 months. It's about 5 months since the first case of COVID, or the first cases were reported in China, in Wuhan. And the numbers have been going up since then. This is this is an infectious disease caused by a severe acute respiratory syndrome, coronavirus 2. And the symptoms are similar to influenza virus. And from the map of the world you can see over there, it's basically trying to illustrate the burden of the disease. You can see Africa. If you look at the other regions of the world, Africa, we are still not having severe cases as the rest of the world. In Kenya, the first case was reported on 12th of March, and up to yesterday, we have 208 cases. And the map there is trying to illustrate the areas, the regions under which is trying to illustrate the regions that have been affected in our country. And you can see this might have changed because this is coming from last week's and these are an epidemic that needs all stakeholders to come in and assist in management of this. And from the world over, fever, cough, and fatigue have been the most presenting symptoms. This is coming from the government briefing of 12th this month, and you can see the symptoms. Majority of the patients are symptomatic. We can thank God for that. But again, to just illustrate what we are getting in our country, you can see also the majority of the cases are presenting with fever. And this is also what has been seen. Yeah, sorry for that, some technical challenges here and there. And now the management of this particular epidemic needs consulted and all stakeholders to be on board. And as you can see, this is the main point of discussion is around the challenges we are facing as a country. Now, from a KNH point of view, there has been a lot of support from we've been having regular training and teaching sessions from the infectious disease unit and the team from the epidemiology department. Availability of imaging equipment, this is a challenge world over, not just in Kenya, but from our unit, we've been able to acquire some machines. And some of them are dedicated to the management of these particular patients. In the effort to avert the spread of disease within the institution. Qualified personnel, this is again not just a local problem, but it is a challenge that many institutions have been facing, and you realize even the developed world. The other day there was an advert about the same issue, because this pandemic actually has stretched the resources that we have. Training and personal protective equipment. This is something that has to be done on a daily basis at a departmental and an institution level. And this one, Kenyatta National Hospital has always been in the forefront of training its staff on the same. Now, in such a pandemic, provision of imaging services and basically medical care to the large number of people walking into our institutions is a challenge, and this is not just for us but everywhere. And as an institution also, you realize there is one of the measures is social distance, and now you find you have a large number of patients coming in, and you have to reduce the number of staff and patients within any particular unit within the institution, and that complicates the whole essence of handling the patients that you are facing as an institution. And this one, you realize also you have to keep the infection control measures, which prolongs the service time to the patients. In Kenyatta National Hospital, we've allocated some portable imaging equipment. That's the X-ray machine, portable X-ray machine, and ultrasound. But in countries where the resources they are able, also you find allocation of a portable CT scan. These are a challenge, because also the moment you realize with the numbers we are getting, even the portable CT scan machines might not be sufficient in any particular country. And one of the measures as an imaging department we can put in place is to find, especially for patients who are coming in for ultrasound, you can image them behind a glass wall. This is basically infection control measure. And because of the resources in many countries, you find that X-ray has come out as one of the most important imaging tool in this particular patient, not because of the unavailability of the CT scan machines and the challenges one faces while transporting and also imaging these patients within those particular units. Additional precautions should be taken, and this is to all healthcare workers, that there are patients some of the procedures increase the risk of aerosol emission from the patient, especially for those patients who are harboring the virus. And some of these procedures include the patients who are on non-invasive ventilation, patients on tracheostomy. During cardiorespiratory resuscitation, these are difficult one to the healthcare worker, whether to choose to resuscitate the patient or otherwise. And then we have those patients who are undergoing lung biopsy, and those are patients with image-guided insertion of chest drain. These at a departmental level, we have a workflow plan, and this is the standard operating procedures, triage of patients, and the justification of the particular imaging studies that has to be done. Now, the standard operating procedures, this is to aid in the management of patients, but at the same time, this helps in preventing cross-infection within the unit and to the health workers. As a hospital, we already have a standard operating procedure in place to take care of that. And then when it comes to triaging of patients, we've already as a department set up a triage desk at the entrance of the department, and this basically to make sure that all patients coming into the unit are screened at the entrance, and for possible, and the patients and the escorts. This is basically to try and take care of infection within the unit. And then all the patients coming in also, it is mandatory that you must sanitize your hands at the triage desk. And also the request forms are evaluated at the triage desk and by the clinicians within the unit, and it has to be, it must have a relevant clinical history, and also a mandatory questionnaire has to be filled at the triage desk. All patients who are coming in for chest exams, that is the chest radiograph or CT scan, also must fill this questionnaire assisted by the referring clinicians. And the patients coming from outside the hospital, then they are assisted at the triage desk to fill the questionnaire. Now here for the healthcare workers and that includes the radiologists, this is one point that that needs to be evaluated keenly, and that is the justification for that particular imaging the patient is coming in for. That is weighed against the radiation exposure, risk of transmission to the healthcare workers, the consumption of PPE, that is the personal protective equipment, which you realize world over there has been a shortage even in and then the cost of equipment.
If you do actually the font, you see the font, the slide almost becomes full, so it is very visible. So you can see. This one, what has happened? No, I think you're back.
Hello, good afternoon. Sorry, just give us 2 seconds to sort out the presentation. We're having a few network challenges, but we'll be back online right now. Thank you all for your patience. We apologize for the slight technical hitch that you are having. Our network seems to be fluctuating, but we'll be back online in a few minutes, just a few seconds, not minutes actually. Good. All right. Yeah.
Sorry for that. Now we are looking at handling of the patient within the department, and all patients who are coming to the department must have a fully filled questionnaire, and all suspects or confirmed cases should be imaged at the respective isolation units. I know this might be a challenge in some centers, and for that reason, then there is need to set aside a specific room and specific machine for imaging of this particular patient. If you can't, you are unable to get maybe the portable machines to go image that patient from the point of. How do I go to the next? Okay. Now for the radiology personnel, these are pictures of some of the radiology personnel in our unit, and some of them are within the isolation unit. And if I might just go through the picture, this is a portable X-ray machine, and you can see our staff here. This is the normal surgical gown. Let me just say that for those people handling patients who are not suspected or confirmed cases, these are the precautions we've taken as a department, and this is basically to protect the staff and also the other users of the unit against this particular infection. And if I was to mention, you can see he is in a normal surgical gown. This is the sterile surgical gown, and these are disposable actually. Then he has gloves, and you can see there is a surgical mask. Then he is in a goggles, and the goggles, these ones are reusable after disinfection. And then he is in a normal cap, the surgical cap. Now for the detector, you can see in this particular image, the detector is covered with these are the refuse bags. It is covered, and most of the time we normally cover it into two bags. The inner bag is the yellow one, and then the outer bag is the red one. The red one is in contact with the patient, and that one, now after you've imaged the patient, the red one is disposed of. The two bags are disposed of, but the red one is the more infectious because it was in contact with the particular patient we are imaging. And then as you get the bag off the detector, then there should be an extra person to pick the detector as the person who did the exam is exposing it, to pick the detector for processing. Now, for the isolation unit and those people in contact with confirmed or suspected cases, then full gowning is important. And as you can see, the personnel here, you see they are in the isolation gown, which actually WHO recommends it should be a waterproof isolation gown. They are in isolation gown. They are on a N95 mask, the goggles, and then they are in gloves and boots and the foot cover. This one, it is important. It is important that the personnel go in contact with the patient. They have to be two, and that is basically one, to make sure that infection control protocols and procedures are followed, and two, also it's basically to support each other in whichever procedure they are doing. This is the slide I've been talking about on that photo. I'll not go through it again. And then there is the room that this patient should be imaged in. Now, at KNH, we have a specific room for imaging of these particular patients. And this one within the radiology department, we've tried to separate all patients coming for chest examination, that is the CT scan and X-ray. We try to separate the rooms from the rest of the general patient. And two, for people who can't afford such rooms within their unit, then there is need to put in place some of these measures I'm going to talk about. You clear rooms for all non-essential accessories and equipment. and the standard infection control procedures should be applied. And in some centers, and you can put up temporary imaging rooms for this particular patients. Now, WHO recommends cleaning of this particular equipment, the imaging equipment, with with water and soap, and then for that is for the suspected and general imaging patients to be imaged. And then there is we have to develop a cleaning schedule that is for the general rooms. For the rooms that you are using to image suspected and confirmed cases, those rooms should be cleaned after every procedure. You don't need to come up with a schedule for that, but after every procedure, they need to be cleaned. And then disinfection after cleaning must be done, and 0.5% chlorine can be used. But many of the imaging equipments, there are guidelines set aside by the manufacturers. You might need to look at the guidelines set aside by the manufacturers for different imaging equipment. And then these rooms must be fumigated, especially for those ones who are dealing with suspected and confirmed cases. But also for general radiological procedures, the department needs fumigation in a scheduled manner. Thank you for that.
Good afternoon. My name is Dr. Rodriguez. My name is Dr. Rodriguez, and I will be going over the imaging guidelines that we have developed here at Kenyatta National Hospital. And I think the first thing to emphasize is that the definitive test for coronavirus is a real-time reverse transcriptase PCR test. And although this has been shown to be highly specific, there have been a lot of issues with sensitivity being reported to being as low as 60 to 70 and as high as 95 to 97%. So with this concern of the false negatives, it's where there is a big need for imaging, because at times you may be required to repeat tests on patients who have tested negative so as to completely exclude the disease. So the role of imaging, there's a huge interest in the role that chest imaging can help with not only screening, diagnosis, and management of patients. This is especially due to the limited availability of the viral testing kits. But we must remember that our key role as health practitioners is to reduce the morbidity and mortality of patients, as well as minimizing disease transmission. And we must remember that we need to protect the healthcare personnel who are in contact with the patients. So currently, there is a lot of information coming out. There are a lot of publications being produced, but we must remember that a lot of them are not complete or up to date, because this is a new virus and we will continue to learn as we go on. The role of imaging is important in triage, in guiding diagnosis, and of course, management. But we need to keep in mind that we have to have clear infection control guidelines in place. Now, the CDC towards the end of March came up with with their protocols, And a lot of countries worldwide have mirrored their protocols with some variability. But what they came out and said is that they do not recommend the use of CT or chest X-ray in the diagnosis of COVID-19, and that viral testing from collection of samples from the nasopharyngeal and from the oropharynx remains the main testing for confirmation of COVID-19. And even if you have radiological findings which are suggestive on chest X-ray or CT, you still need to carry out viral testing. This is mainly because we know that the findings on chest imaging are not specific and may overlap with other viral infections. So here at Kenyatta Hospital, we've made our protocols that we are currently using. A lot of this, like we've mentioned, we shall continue to learn. They are adaptable as things evolve. And so currently we recommend the use of chest X-ray for patients with mild symptoms, but those who have a risk of, have risk factors for disease progression, such as age above 60, cardiovascular disease, diabetes, immunocompromised patients, patients with renal failure. It's also useful for patients who are COVID positive and have moderate to severe symptoms. And one may also remember that we can use it for patients who have an epidemiological contact, such as they have a contact or they have recently traveled and have moderate to severe disease. And even though the initial viral test may come back negative, the use of chest X-ray in these patients may help not only suggest an alternative diagnosis, but perhaps flag the clinician into the need for for repeat viral testing. And of course, we shall continue to use the chest radiograph to monitor disease progression and any worsening of respiratory condition of the patients. But to note is that for a lot of the patients who will present with ARDS, that we do not recommend daily chest radiographs as is usually done, especially if the patient is stable and intubated. And with each case, we will want to take it individually and do clinical assessment and discussion prior to imaging the patients. It may also be useful in centers where there's a long turnaround time or viral tests are not readily available. And for those patients with moderate to severe disease, it can be used to triage patients towards isolation. Now, chest X-ray, it's not indicated for as a screening test, and it is not indicated for asymptomatic patients or patients who are COVID positive with mild features, but do not have risk factors of disease progression, as we have discussed. Now, the CT scan, we know that it's pretty sensitive, and the findings may even present prior to symptomatology. But we must remember that the findings on the CT chest are non-specific and may overlap with other viral infections and pneumonias. So we do not recommend it as a screening tool or for a first-line test to diagnose COVID-19. Then we will be using it sparingly and be reserved for hospitalized symptomatic patients with specific clinical indications for the CT. So this is where we hope to to have a team approach to each of the patients, together with whether it's the intensivists, the infectious diseases specialists, the pulmonologists, and look at the patients on a case-to-case basis for evaluation on whether they need the CT scan. Now, CT is indicated in patients with functional impairment or hypoxemia after recovery from COVID-19. And what may start to happen, and perhaps some centers have already seen, is that sometimes you may have a patient who is imaged for something else, and they're incidentally to have findings suggestive of COVID-19, and these patients should be flagged for viral testing. So we have also adopted the protocol that is being used in most centers across the world, that we recommend a non-contrast CT chest with thin slices. And in patients who would need IV contrast, those with hemoptysis, then what we will be doing is running a non-contrast scan prior to contrast administration, as a lot of the radiologists will know that contrast may impact the interpretation of ground glass opacities. Now, ultrasound and point of care ultrasound, it's an area where there are a lot of studies, especially coming out of Italy and China. And here at Kenyatta Hospital, we have points of care machines, ultrasound machines in the infectious diseases and isolation units. It is emerging as a tool that can be used not only for triage and monitoring and follow-up of patients with COVID-19, but generally in patients with acute respiratory failure. But you must remember that a lot of the findings, such as the subpleural consolidations of the multiple B lines, are not specific for COVID-19, and that at times even a normal ultrasound does not exclude that the patient could have COVID-19. So this is generally the approach we have taken, having borrowed from our colleagues in New Delhi. And this is just to summarize just what I have been talking about our imaging approach to patients. That basically for your COVID-19 suspects, viral testing will be paramount. Then for patients with moderate to severe disease, the chest radiograph will be required and will be continued to be used for monitoring of progression of worsening or improvement of disease, while the CT will be reserved under discussion with the intensivists and the infectious disease specialists, while we use the chest radiograph for mild cases, those with severe risk, high risk factors for severe disease. Now, I'll briefly just touch on a lot of the imaging findings that I'm sure a lot of you have been seeing. And we know that the findings can be found in that COVID can be divided into 4 stages: the early, the progressive, the peak, and the transition stage. And a lot of the findings can overlap. And on your chest radiograph, typically what you're going to see are ground glass opacities. They tend to be wedge-shaped at the periphery or under the pleura. And you may find that the wedge shape points towards the hilum. They have a predominance for the middle and the lower lobes. And at times you'll find that the densities will be variable in the early stage. But as disease progresses, what happens is that the ground glass opacifications, their density begins to increase, they become bigger, but you still maintain the wedge-shaped appearance, with sometimes pointing towards the hilum, while also the predominance tends to be towards the middle and the lower lobes. This is one of our patients who was classified as moderate to severe disease, COVID positive patient. And this patient, where you can see that the chest radiograph, the ground glass opacities now have started to coalesce and fuse together. And they are patchy, they are now diffuse throughout both lung fields, both in the upper and lower lobes. And as the disease continues to progress, what happens is you get more whitening of the lung parenchyma, you get bigger opacities, you get areas of consolidation, you get air bronchograms seen bilaterally, diffusely throughout the lung fields. On chest CT, the main findings that you will see, especially early, are the ground glass opacifications and the bilateral involvement and posterior distribution. And in the early stages, the ground glass opacity, you will see the ground glass opacities with crazy paving. But as you progress, the ground glass opacities become more extensive, and as the disease progresses, we end up with more areas of consolidation. So this is an example borrowed where you have an early stages where you have ground glass opacities, which predominantly are subpleural or to the periphery. They are predominantly at the lower lobes and posterior. And in the early stages, you won't have too much consolidation or architectural distortion. And similarly, we can see the predominance towards the periphery and the posterior aspects and lower lobes of the lung. As the disease progresses, then you will see more ground glass opacification. It will start to form consolidations and areas of bronchiectasis, as well as areas of fibrous bands in more severe disease. Similarly, in this patient, where you have consolidation at the posterior aspects of the lower lobes, and this is a patient who was positive, and this is more severe disease. Other patterns that do show up are crazy paving, which are really a mixture of ground glass opacification with septal thickening. You can get vascular dilatation and traction bronchiectasis, as well as subpleural bands. And then you have the transition, which sometimes is also called the absorption stage, where basically what you're having is the resolution of a lot of the findings. They become, whether it's the ground glass opacification and the consolidations become less dense, and they start to resolve, and you may have areas of fibrosis. So for example, in this patient who has a ground glass opacification near the mediastinal pleura and density of the lower lobe subpleural region, after hospitalization and resolution, we start seeing resolution of the ground glass opacification with, as well as the lower lobe density resolving with areas of fibrosis. Now, our next step here at Kenyatta Hospital, and something that has been recommended by many centers worldwide, is to come up with a standardized reporting and scoring system. And there are various systems that are seen, and I've given you two examples here. The CORADS, which is by the Dutch Radiological Society, while this is endorsed by the RSNA and the American College of Radiologists. So the importance of standardizing reports is not only do the reports read more clearly, but it will help the radiologist communicate efficiently and be able to triage any patients, if you have a patient who has findings, towards getting either whether it's a repeat test or their first testing, as well as enabling the radiologist work together as a team with the intensivists and the infectious diseases specialists, because when developing these standardized reporting and scoring systems, it's imperative that they are on board and are able to give an input, because each center may need to tailor it based on what are the needs of these particular center. Thank you.
Okay, hello. We have Dr. Umaru who's presenting next. Dr. Umaru, where, let me look for, oh, I've already seen you. Okay. Yeah, all right. Santi, Doctor. Hello, Dr. Umaru. Hello, we can't see you, we can't hear you. Let me see if I can, we can start your video. Dr. Umaru is presenting on our local cases, the ones that we've encountered here in Kenya. So we really hope that his sound will be working. Yes, Doctor, we can see you now. Hello?
You can hear?
Yes, we can hear you.
Okay. Thank you very much. So mine are a few case studies that I've gathered, and I will straight away just go to case one. A 60-year-old who was admitted at Jocham Hospital on around 31st March. The patient had presented chest pains and had difficulty in breathing. Chest X-ray was done, which showed hazy infiltrates, left lower lung. A repeat chest X-ray done 4 days later showed an increase in the pneumonic changes involving now both lower zones, but more in the left. For some reason, the patient was done MRI, which we were able to pick bilateral pleural effusion and the pneumonic changes. At this moment, I think they were brought for me for review, and I advised on CT. So because of the difficulty in breathing, so the CT was done. I will share with you the images. Of course, out of the laboratory, the D-dimer was raised. So a PCR test was also done, which was which was raised, which was negative, which turned negative. Nasal swab also for COVID-19 was negative. If the patient had no history of travel outside the country, he was later admitted in Mombasa Hospital, where now this CT scan was done. At Mombasa Hospital, they put the patient on treatment isolation. So now the CT scan, I don't know whether you are able to see, but it's a video, and you can see the infiltrates, the ground glass, beginning from the lung apex, and mostly peripherally placed, and they are pointing towards the hilar, and those are the ground glass appearance. This was the first CT that was done, and I'll share with you again after treatment for a week, almost a week, up to last Friday. A second CT scan was done. I think the doctor requested that. They shared with me. Just like the last presenter was saying, the ground glass appearance is now like clearing, but we have fibrotic changes more. So, hello? Am I disconnected?
Hello, yes, continue, doctor, we can hear you.
You can hear?
Yes, we can.
So this case, while at Mombasa Hospital again, they have done nasal swab twice, turned negative, but the patient was discharged recently and is doing well at home. The patient is doing well at home. Was put on hydroxychloroquine and azithromycin. Now, she believes that, just like somebody was saying, we don't know because the swabs were negative, but yet the X-ray and CT at these findings, I don't know what other people's opinion are regarding the first and second CT. Now, I'll go to case 2. The patient was seen on 2nd April at Mombasa Hospital again. In a clinic in Mombasa. He had a previous contact with a known COVID-19 patient. Of course, the known patient passed on. The patient had fever, cough, difficulty in breathing, and general body malaise. So nasal swab done was positive for COVID-19, and the CT images are shown in the video below. The patient is recovering well, but still admitted in the hospital. This is the temperature chart of the patient, 38, 37.6. Yeah, coughing, but not vomiting. These are the CT video. You can see the peripherally based ground glass appearance, and this is more diffuse. and extending to the healer. So you can see the lung architect. Of course, there are fibrotic changes as well. So this was a confirmed case of COVID. We have not done any other, and there is no X-ray that was done preceding this. So I'll go to case 3. Now, case 3 is a patient has a known history of travel to Germany and was seen by a private consultant in town, Mombasa, on 27th February, who requested MRI cervical spine. I think the patient had presented with some other problems of the neck. Patient went to Mombasa Hospital, and the report given, the MRI report, I didn't manage to get this report of the MRI cervical spine, but reported back on 10th March, and at this time had complaints of chest pain. He was admitted at the hospital briefly. A number of tests were done, including abdominal ultrasound, chest X-ray, CT scan, and echo. The D-dimers was raised. So they again asked for CT angiography on the basis of ruling out pulmonary thrombosis, and it turned out to be negative. All the radiology tests, therefore, were reported negative as then. The CT images are shown. I'll show them, and the patient was discharged on 12th March. So all this time, patient was not being managed as COVID, so he was not isolated. But later, this patient went to Bangathi and turned positive for COVID. And when we reviewed the CT scans again, and I will share retrospective. I'll jump those findings. So this is the CT scan. And it was done on 12th. And if you look, generally both lungs are generally clear. As at then, it was reported by the radiologists there to be clear. But on retrospect, there could be some very early focal consolidations like there, peripherally, but they were initially not very conspicuous. And they did a volume CT, which now I will present after this, which was able to capture some focal infiltrates. Yeah, this is the volume CT reconstruction. And if you look carefully, you will find some focal areas. Yeah, like there, some focal densities. And this was early on 12th March, though the patient turned much later positive. So that is that case. So finally, I have my 4th case. The case is a patient who traveled from Mombasa on to Western. Maybe this case is known to majority. He arrived at home on 7th and developed, and on 10th he developed symptoms of cough and difficulty in breathing. He was rushed to Matibabu Foundation Hospital in Ugunja, Ukwala, I think, hospital, where he was isolated as a suspected case for COVID-19. He died 2 hours later. On 11th, blood specimens were taken to Kemri, Kisumu, and he tested positive for the COVID-19. Yeah. So I managed to get, the doctor shared with me the X-ray, and there was an earlier discussion about the X-ray presentations, which this I see conforms to what our colleague at Kenyatta was talking of. Predominantly lower lobes, and then the wedge densities, which are peripheral. Of course, the ground glass appearances here, and this was the the case. So I think as per the X-ray findings, it conforms to COVID. But again, here the swab was positive. So those are the cases that I have today.
Thank you so much, Dr. Omar,
Yes.
for that presentation.
Yes.
And we are very excited that we've seen actual films that we've done, which means there are quite a number of questions that you'll answer. I've seen one, and I don't want to speculate on that answer, but we've seen one question. I think now we can move on to the Q&A session. Asante sana Daktari for that input from Mombasa. So let me start with the first question. And the first question is to the presenter, Dr. Herbert Murai. There's a question from Asu, although I can see you've already answered it. Sorry, from Chris Chebeda. And Chris is asking, in section 1, you suggested that all technicians are wearing surgical gowns, masks, and caps, even non-COVID patients. Are the sonographers also wearing these gowns all day? Dr. Murai?
Thank you for the question, Isabella. Actually, this is what you saw me presenting is for all technical staff handling the patients in the unit, and the sonographers are part of the technical staff. So that we came up with that particular protocol because you find the sonographer actually most of the time they are almost you can't keep the recommended 1.5 meter distance from the patient, and the best way to do that also is to make sure that you are putting on the gowns you're putting on are protective. We recommend that everyone within the department is in scrubs because that is it's easier to clean. And then the surgical gown is actually disposed immediately after you finish examining your patient. But that does not apply to the people in contact with the patient. That is for the rest of the staff dealing with the general population within the general public within the unit. Thank you.
Okay, thank you so much for that, Dr. Murai. I'm sorry about the echo. Sorry about that. Dr. Murai, still in the same breath, there's a question from us when she's asking, after every encounter, now that we're wearing this PPE, are we changing after every encounter? Once we finish with the first patient, do we change again for the next patient? Or are we wearing them throughout the whole shift?
Now, we have two categories of patients over here. We have the general public, those who are coming in for any other exam, and those patients who are suspected or confirmed to have COVID. Now, for the general public, the only thing that needs to be changed after every patient are the gloves. Now, for the patients who are in contact, for the staff who are in contact with the suspects and confirmed cases, you need to, the technical is called doffing and donning. You remove the PPE after getting in contact with that patient as you prepare for the next contact.
Thank you for that response. We have Dr. Onyambu. Dr. Onyambu, let me unmute you so that you can ask your question. Hello, Daktari.
Hello. Yes, thank you, Daktari. My question is to Dr. Umara and Dr. Rodriguez.
Okay.
Now, regarding the first case that Dr. Umara has presented, the features that show peripheral ground glass opacity, they look like the typical COVID-19 presentation on CT scan. And yet the nasopharyngeal swab is negative. And this is also what has actually been seen in other studies which have been published so far, that there's a situation where sometimes you find that the sensitivity on the RT-PCR test is not so sensitive. It could miss a small number of cases. I think initially it was like 80%, now it's about 97%. So in that case, where the CT shows the features, but the nasopharyngeal swab is negative, wouldn't they still treat that patient as having a COVID-19 disease, because that has been documented in other places? And then also a ride on that is that now where you have, because of the increased turnaround times, where you have severe, moderate severe disease, cannot CT be used to guide the management of the patient as you still wait, because you still need to follow these patients. And as we have seen, what has been presented is that they deteriorate very fast. So having that initial CT helps you to actually triage the patient and see this one has severe to moderate disease, and then you're able to manage them accordingly. And then the final one, the patients who are coming in with moderate severe disease who need ultrasound, are the sonographers and the radiologists donning the full personal protective equipment to protect them from infection, because it has been shown that if you're going to have an interaction that is so close for more than 15 minutes, then you need to actually protect the radiology staff. Thank you.
Okay, Dr. Mara, if I've understood your question, you've asked about should we have CT scan as the gold standard for testing now that PCR is proving to give us some false negatives? And the second one was on PPE.
On the cases where you can actually see the patient meets the case definition,
yes,
has the symptoms, but yes, the PCR is negative.
All right. So, Dr. Mara, should we have that as the gold standard for testing?
Yeah, that is my thought, that CT, especially patients who are
Hello, Doctor.
being negative, and this finding, as you saw, initiated and then fibrotic changes. Now, the problem we have in this particular is actually was treated as was isolated. It was put on the medicines which I said, and this is the family and the rest, because you don't know much as the nasal swab was negative, but there was, with the CT findings, those precautions had to be taken. I managed to talk to the patient herself today. She's discharged, she's at home. And her own belief is that she was mistreated. Having been isolated, they went through a lot of trauma, isolated, and yet she's believing only in the nasal swab, because 2 more were done at Mombasa Hospital and turned to be negative again. So she believes that maybe on her case it was just pneumonia. But if you look at the, I agree with Dr. Nyambu that the missing, and I don't know how the sensitivity of. Thank you. Hello.
Okay, thank you, Dr. Onyango, for the question. And just to add on what Dr. Umara is saying, supposing the PCR is negative and the chest CT findings and the CT findings are suspicious of COVID, what do you do? And I think the first thing that we should do is to isolate this patient and to call it suspected COVID and repeat the swabs just the way they are done, but treat the symptoms of the patients. As we know that ground glass opacity was there before COVID. So the history of this patient is very important. And if they've had a history of contact, then we isolate them on the view of CT. But we still need to know whether is this really COVID or not. And so that's why we are saying that imaging and the labs are complementing one another. In Kenya, we are not yet screening all our patients, doing routine chest X-ray for every patient who comes with suspected COVID. However, when the patients have chest symptoms, then we do it. The first screening test we do is the labs. But if a patient comes with chest symptoms, then we have to do the imaging. However, the dilemma comes in when the labs are now negative. What do you do with this patient? If the history is leading you, then you have to isolate this patient and repeat your lab. You had also asked about ultrasound.
Okay.
And we've divided our ultrasound into two: the routine ultrasounds that we do in the department and the suspected cases. If they are suspected COVID cases, then the person doing the POCUS, which is the point of care lung ultrasound, then they have to don themselves so that they are not infected. And there's a clear criteria on how to do the chest ultrasound, the lung ultrasound. It's not routinely being done here, but we have few doctors who are doing the lung ultrasound, and precaution has to be taken because you're in close contact with the patient. Thank you.
Okay, Dr. Nyabanda, in the same breath, there's a question from Asu, and Asu is asking, how often should we disinfect the radiological equipment to reduce the transmission of COVID-19?
I'll ask Dr. Murai to answer that.
Yeah, I'll take that one. Now, for suspected and confirmed cases of COVID, the radiological equipment are disinfected immediately after the exam. That means after every patient, there has to be cleaning of the equipment, cleaning of the room, disinfection of the equipment, and fumigation of the equipment. For the general work, then that you leave it to the department. Most of the time for our department, we do twice a day, disinfection of the fumigation of the department and disinfection of the equipment. But different centers also they have their own different protocols on when to disinfect the department or when to fumigate the department. Thank you.
Thank you for that. There's a question from Judy Mashuka. And Judy is asking, if diagnostic imaging is not recommended as a screening tool, what is the plan to have adequate PCR tests to screen asymptomatic and symptomatic patients? Judy, that's a very good question. That's a very good question. We will let Dr. Rodriguez to take that one. So Dr. Rodriguez, should we have PCR tests as a screening tool for symptomatic and asymptomatic patients? Hello? What's your con? Okay. Hello, sorry, Dr. Rodriguez's device is currently not connected, so we can't hear his audio, but Dr. Nyabanda can be able to answer that question. So Dr. Nyabanda, should we have PCR testing as a screening tool? All right, sorry, we're saying that most of you have not been able to hear that response. We'll come back to that. Ceresia, I'd seen your hand raised. Was it about the audio? So Dr. Nyabanda, they were not able to hear your response. Kindly, there was no sound, eh? Okay, so we'll go back to the next question from Michelle Gatecha. And Michelle is saying, thank you for the presentation. Is there provision in your institution for serial imaging, whether chest X-ray or CT scan chest, for moderate and severe cases? If so, what is the imaging interval?
Hello. Yes. So when it comes to serial imaging, what I was trying to emphasize is that this is not like any other patient with ARDS or, am I still? Yes. So this is not your typical ICU patient. This is not your typical viral pneumonia. And there are many concerns about exposure of healthcare personnel, the availability of PPEs. Now, if we got to the point where all that was available, then we could consider doing more imaging. So even with the discussion currently with the intensivists at our hospital, we look at it that the best way is to approach it from a patient-to-patient basis, because although there are studies that show that the features of ARDS radiologically and clinically do match, they do also admit that it will help them with some of their vent settings and management of the patient, but it not, there are studies which show that it will not change the prognosis of the patient, although it does help. So currently there is no fixed guideline that you should image after every 2 or 3 days or daily.
All right, thank you for that, Dr. Rodriguez. We profusely apologize for the network challenges that we're having today. We have 8 more minutes to end this session, and there's a comment from Dr. Elijah Kwasang, and he's asking there are algorithms in Italy and UK that recommend using imaging with clinical parameters in resource-limited areas for classifying COVID likely or COVID suspect cases, and inform treatment pending PCR, and in some cases necessitate repeat PCR when negative. The SCR guidelines do not factor resource-limited practice, the ones that Dr. Rodriguez presented. Can we utilize the clinical radiological diagnostic criteria to inform treatment and isolation of patients pending PCR? Dr. Omar? Hello, Dr. Omar. Okay, Dr. Rodriguez, Dr. Omar seems to have dropped off.
So thank you, Dr. Kwasa, for the question. And what you say is absolutely correct. But at the same time, this is probably a discussion that we should be having nationwide, because we need to come together as not only as radiologists, but as clinicians and decide at what point do we want to image these patients. We know, like I just previously said, the availability of PPEs, the availability of the viral testing, the turnaround time is improving. So there is, how can I say, there is the potential for using CT or chest X-ray for screening for triage. But at this point, the position that we have taken is to minimize exposure of healthcare personnel, to minimize the use of PPEs until we're sure that they are adequate for the increasing numbers.
Okay. Thank you for that presentation. I'm seeing questions about from James Kihumba. James, we will not be able to answer your question at the moment. You're asking us, so our first case may have been as early as Feb 27th from Germany. We will not be able to confirm or deny that. Thank you for that comment. From Asu is still on PCR and CT scan. I believe that has been answered. And Dr. Asu, I'd like to let you know there's no perfect test. All testing modalities will either give us a false negative in some cases, depending on the technique, depending on the skills, depending on the patient factors. So we really cannot say that for this case, the first case that was presented where we got a negative PCR, but the CT scan showed us features that we can be able to qualify that as a COVID-19 case. But as we've been told that serial testing might be a good opportunity to be able to, and a repeat PCR might be a good opportunity to be able to confirm these cases or not. There's a question from Christabel. Christabel Kaemba, I'd like to park your question in a parking lot because we have PSK coming to present next week on treatment and adverse events, reported adverse events. So we have a team from Pharmaceutical Society of Kenya who will be able to answer your question. They're also working in conjunction with the KNH pharmacy team. We have a question from Nelson Mukora, and Nelson is saying maximum danger to exposure is what is with the unsuspected cases. Shouldn't we wear protection throughout? Dr. Murai, should we have protection throughout, suspected, unsuspected, now that we don't know who has the disease, who doesn't have?
Thank you for the question. Actually, the stage at which we are in right now, everyone is a suspect. And that's why you can see even for our department, there is a minimum anyone attending to a patient is required to have. That is just an effort to try and reduce the chances of infecting the staff. And also it means also by the staff also putting on like that also the chances actually is basically to reduce the infection, the cross infection in case a patient is still within that clinical period. And also, if you remember very well in my presentation, I also talked about the patients coming in. Every patient should have a mask when coming into the unit. That actually goes to say that everyone is a suspect if we look at it from even the presentation we got from Dr. Umar from Mombasa. Thank you.
Okay, Dr. Umara, let me unmute you because there's a question for you specifically from Mercy. And Mercy is asking, Dr. Umara, you mentioned no use of steroids for any of the cases. Any impact on CT changes of lung fibrosis where prophylactic steroids have been used?
Hello.
Hello, we can hear you, Doctor.
Yeah, could you repeat the question again?
Mercy is asking, you mentioned no use of steroids for any of the cases that you presented.
Oh,
and
yes,
she's asking, is there any impact on CT changes of lung fibrosis where prophylactic steroids have been used?
Oh, okay. I will not be able to answer this. I don't have any data on steroid use, but I can, maybe in the next meeting, I can find out from our cases whether it was used. But for now, I don't have any data on that.
All right.
Should the fibrosis be less if we use the steroid?
Hello.
Hello?
Yes, we can hear you.
Yeah, I've not followed up any patient on steroid use as for now.
All right,
Yes.
and I can also see we have a question from you to the KNH team, whether we have a CT scan machine that's dedicated for COVID patients. Dr. Anyabanda?
For the question. At Kenyatta, we have 2 CT scans. And fortunately, because of the challenges, is it in a resource poor country? One of them is working right now, one is not. So we are only using one machine at the moment. So we are just looking at the ICP guidelines of decontaminating the room, fumigating. We wait for 1 hour before we do the next patient if we suspected that we have a patient who is likely to be COVID. So we are using one machine right now. And I think that's one of the challenge in maybe most of the other hospitals. However, for the X-rays, we have enough digital X-ray machines. So we have dedicated a portable digital X-ray machine for the suspected cases. And we have also dedicated ultrasound machines for dedicated patients for COVID suspected cases. Thank you.
We have Dr. Bonasa who would also like to add to that. Let me just find her for 1 minute. In a second. I know we are time bad today, but just 1 second, I'd look for. Okay, 1 second. Okay, yeah. Yes, Dr.
Just to add to what Dr. Nyabanda has done, I've spoken about in our futuristic proposals. We are looking at infectious disease imaging as one of our major issues. And one of our proposals is to have set aside 5 units for CT, ultrasound, and X-ray units for infectious diseases that are not part of the common pool for the routine patients. So in the proposals that we've sent out with the hospital management is to look at having a mobile CT scan machine, mobile X-rays, and also having a PAC system or remote reporting for all the imaging done within the hospital to also reduce the footprint in times of infections like what we have right now. As it is right now, KNH has reduced the footprint within the department by having tele-reporting of all the CT scans being done. All the chest X-rays being done within the unit are also being fast-tracked to the radiologists. The radiographers have been informed that any chest X-ray that they do that seems to have any signs of COVID, they have to quickly alert so that a report is written out immediately. This message has also been communicated to the clinicians that if they have patients whom they've sent for chest X-ray and suspect it could be COVID, then they must get a report immediately. So the unit is already sensitized in terms of turnaround time for all patients who are suspected to have COVID or to be in the lines of suspicious CT scans and chest X-ray reporting.
Thank you so much for that, Dr. Bonase. The final question, and this is from Eric Terrer, and he's asking, how should we maintain social distance when doing ultrasound? Dr. Murai, I think you should expound on that again. How do they maintain social distance when they're doing ultrasound procedure? And what can they do to protect themselves? That's the final question for today.
Thank you for the question. The social distance is advised, actually, is one of the measures in controlling infection. And it has been told several times about the advantages of social distancing. But in a hospital setup, not just in radiology department, even other units, it's a bit difficult to maintain that social distance. Now, for the radiology unit, that's why we came up with a minimum PPE one must have while when in contact with the patient. And this includes the the person taking care of the ultrasounds in the unit, the person in contact with the patient taking the general radiographs, and also the person, the technician in contact with the patient taking the CT scans. So these are procedures that you can't maintain that social distance, but there is also an alternative also of minimal contact. You only get in contact with that patient if there is a specific procedure you are doing, and after that procedure, the patient leaves the unit as fast as possible. Thank you.
Okay, thank you for your response. I let Dr. Nyabanda give us the final word, and maybe Dr. Omara from Mombasa shares a final word. There's a comment from Dr. Onyambu on getting the Aga Khan team on board next time. Thank you for that. We will invite them for the session, but for now we were not able to get them. Probably they're logged in, but not as an institution, as individuals. Elizabeth Jananga, your comments on CPD points, kindly send a message, a private chat to a participant called KNH Webinar Registration. Kindly send a private chat to KNH Webinar Registration or to knhresearch@gmail.com. You can send an email to knhresearch@gmail.com. We'll be able to sort you out on your CPD points. So Dr. Omara and then Dr. Nyabanda, final parting shot.
The discussion being the leading hospital, if you can, as you can see, we don't have one which is uniform in the country. As we talk, for example, so many patients are admitted, isolated, but no radiology request being made. I think people are relying only on the swabs and lab. So I don't know whether we can influence some protocol that can be shared nationwide.
Okay.
Thank you.
Okay, Dr. Nyabanda.
Okay, thank you very much. Okay, thank you very much. Everyone who has participated today, and we hope we have shared with you the pattern recognitions on both chest X-ray and CT, and so many of us would be able to pick any suspicious lesion. However, a negative CT does not mean the person does not have COVID, and also an abnormal CT scan may not necessarily be COVID. So those should be the take-home messages. Dr. Umara, we have guidelines and protocols as KNH, but as the radiology fraternity, we need to come up with one protocol which our chair is working on, and I believe it will be in the ministry soon so that everybody else can follow those guidelines. So thank you very much.
Thank you.
Okay, thank you for that. Thank you all for attending today's session. It was quite informative. We've seen some real work that has been done by the team from Mombasa. Maybe in the next meeting, we'll have a few slides from Aga Khan, Nairobi Hospital, KNH, KU, Teaching and Referral Hospital. We'll be able to see what everyone is able to, what the radiological teams in those hospitals are doing at the moment. We thank you, Dr. Mara, for sharing your experience with us. We thank you, KNH radiology team, for sharing your experiences with us, and also for handling the PPE question for the sonographers, for any person who's working in the radiology rooms. Thank you so much for that. I know it's a hot topic, and we are glad that you're able to address that. So tomorrow we'll be having mental health Wednesday. Again, we have a team for mental health, and we'll be addressing issues of, we'll be addressing issues of stress and burnout management when caring for COVID-19 patients. So thank you all for attending this session. We appreciate you. Meru Level 5, George from Kisumu. Thank you for all attending this session. Have a nice afternoon. Bye.
Okay.